Good evening. Today I'll be dealing with antifungal drugs. Antifungal drugs is otherwise known as antimycotic drugs, and they are mainly used for the treatment of fungal infections either topically or systemically. Let us look at the classification. There are basically 5 categories. The first one is antibiotics, and the antibiotics have been classified into 2. We have cholines, under which we have the drugs like amphotericin B, nystatin, netamycin, as well as hemicin. The second category what we have under antibiotics are heterocyclic benzofuran, and we have the drug griseofulvin. The second category we have is antimetabolites, for which we have the drug flucytosine. The third category we have is azoles, and it is categorized or subdivided into imidazoles and triazoles. Under imidazoles, topical application we have clotrimazole, iconazole, miconazole and oxyconazole, and for systemic purpose we have ketoconazole. And the second subcategory what we have is triazoles, and for systemic purpose we have fluconazole, we have itraconazole and voriconazole. The fourth category we have is allylamine, and we have the drug terbinafine. And the last category is other topical agents, and we have tolnaftate, and we have undecyclic acid, benzoic acid, quinidinoflor, cyclopyroxolamine, butyrophene, and sodium thiosulfate. Let us now start off with choline antibiotics. Now, choline antibiotics, or the word choline, has been derived from its double-stranded structure, and this amphotericin B is just a prototype of it. Now let us see what is amphotericin B. It is obtained from Streptomyces nodosus. Streptomyces nodosus. Now if you see the chemistry portion, okay, this cholines, they consist of a macrocyclic ring, and one side of it consists of several conjugated double bonds, and it is highly lipophilic, whereas the other side it is hydrophilic with lots of hydroxide groups. And a polar amino sugar and a carboxylic acid group are present at one end in some, and all these are insoluble in water and unstable in aqueous medium. Mechanism of action. Now usually it will exert its activity through hydrophilic interactions with cell membrane ergosterol, and subsequently the membranes will be disrupted, okay, of its function, and as a result pores will be formed, and that will cause efflux of potassium ions, resulting in cell death. So this is how it works out in the body. Now let us have a look at its antifungal spectrum. It is active against wide range of yeast and fungi, like we have Candida albicans, Histoplasma capsulatum, Cryptococcus neoformans, Blastomyces dermatitis, and Coccidioides immitis, Turulopsis, then Rhodotorula, Aspergillus, and Sporothrax, etc. Dermatophytes are inhibited in vitro, but concentrations of amphotericin B attained in infected skin are low and ineffective, and in higher concentration it behaves as fungicidal, and low concentration it behaves as fungistatic. Now resistance can be noted in and that it is very rare among the Candida species, that too in a selected group. And it is also active on various species of leishmania. Let us have a look at the pharmacokinetics. Amphotericin B is not orally absorbed. It can be given orally for intestinal candidiasis without systemic toxicity. It is usually administered intravenously as a suspension made with the help of deoxycholate, and it gets widely distributed in the body, but CSF penetration is very poor. It binds to the sterols in the tissues and to lipoproteins in plasma, stays in the body for a long period. The terminal elimination or the half-life is 15 days. About 60% of the drug is metabolized in the liver. Excretion occurs slowly in urine and bile, but urinary concentration of active drug is low. Adverse effects. Now usually the toxicity is said to be very, very high. So we have acute reaction and long-term toxicity. Okay, under adverse effects we have acute reaction and long-term toxicity. Now acute reaction, this will happen with each infusion, and patient will suffer from chills, fever, aches, pain all over, nausea, vomiting and dyspnea lasting for 2 to 5 hours, probably due to the release of cytokines. And when these are severe, the dose is gradually increased. So usually the intensity of the reaction decreases with continued medication. So we have to continue the medication, so these results or the acute reaction will stop. Apart from that, hydrocortisone 0.6 milligrams per kg will be injected with infusion, and that also can reduce the intensity of this acute reaction. Moving over to the second one we have is long-term toxicity. So usually nephrotoxicity is said to occur, and it is dose dependent, and manifestations are azotemia. Now azotemia means when the nitrogen compounds in the body gets increased in the blood. Now which are the nitrogen compounds? We have urea, we have creatinine, etc. Okay, when these compounds get raised in the blood levels, that time we call it as azotemia. Now azotemia, reduced glomerular filtration rate, acidosis, hypokalemia, and inability to concentrate urine. Now it can be reversed slowly and often incompletely after stoppage of therapy. The second thing what we can notice over here is anemia under long term. Okay, apart from that we have anemia, and patient also will start off with CNS toxicity. Okay, now anemia will be seen in slowly, it will be a slow development, and it can be due to the bone marrow depression, and it is reversible. Whereas the CNS toxicity, it happens only on intrathecal injection, and you can identify it with the complaints from the patient like headache, vomiting, nerve palsies can be noticed. Now uses. It can be applied topically for oral, vaginal and cutaneous candidiasis and automycosis. It is the most effective drug for various types of systemic mycosis and is a gold standard of antifungal therapy. Okay, gold standard of antifungal therapy. But due to the higher toxicity of amphotericin B, the azole antifungals are preferred in conditions where their efficacy approaches is more than that of the amphotericin B. And another use is in leishmaniasis. Okay, in leishmaniasis. Interactions on administering this drug, and if you are administering it with flucytosine, which is an antimetabolite, you can find that it has a super additive action with amphotericin B, and it increases the penetration. This amphotericin B will increase the penetration of this 5-fluorocytosine into the fungus. So it enables a person to get benefited from it. The rifampin and minocycline, like if you might have gone through the anti-leprotic drugs and all, you have this particular drug again, rifampin, antitubercular once again. The drug has been mentioned over there. So rifampin and minocycline, okay, though they are not antifungal, they potentiate or they increase the efficiency of amphotericin B action. Aminoglycosides, vancomycin and cyclosporin and other nephrotoxic drugs will enhance the renal impairment caused by amphotericin B. So we need to be careful. If we find out that there is aminoglycosides, vancomycin or cyclosporin or any other nephrotoxic drugs, it's always best to avoid when we are administering amphotericin B to the patient. So this is all about amphotericin B. Moving over to the next drug, nystatin. Now nystatin, it also possesses antifungal action and also other properties just like amphotericin B. And due to its high systemic toxicity, it is used only locally in superficial candidiasis, and it is generally preferred over amphotericin B for these purposes. Usually it will be given orally, it is not absorbed. It can be used for monoleal diarrhea, which is being caused by superinfection, and it will be given at a dosage of 5 lakh units 3 times a day. Nausea and bad taste in mouth are the side effects of this particular drug. Now this is effective in monolear vaginitis and oral thrush, and also corticosteroid aerosols can also cause oral candidiasis, and nystatin is very effective in preventing this particular problem. And also it is used in corneal, conjunctival and cutaneous candidiasis in the form of ointment. No irritation or other side effects are seen. Candidial resistance to nystatin is not a clinical problem. It is ineffective in dermatophytosis. So this is all about nystatin. Next drug is hamycin. It is similar to nystatin, but it is more water soluble. A fraction of this drug is orally administered is absorbed, but it cannot be relied upon for the treatment of systemic mycosis. We can't rely fully on for that particular problem. So the use is restricted to topical application for oral thrush, cutaneous candidiasis, monoleal and trichomonas vaginitis, and otomycosis by aspergillus. And the last drug, natamycin. It is similar to nystatin. It has a broader spectrum of action and it is used only topically. 5% suspension or 1% ointment is non-irritating to the eye and has been used particularly in Fusarium solani keratitis. Both monoleal and trichomonas vaginitis are amenable to natamycin. So with this particular class, I have completed the poly antibiotics. So in the next class, I'll be dealing with heterocyclic benzopyrin. So till then, take care.